Uh, Today my presentation is Airway Assessment in Emergency Department. Good evening, everyone, respected faculties and my colleague. I, Dr. Sunil Kumar Das, third year resident, will be presenting on Airway Assessment in Emergency Department. Starting today's presentation with why we need to assess airway in ER. Mostly we assess airway in ER when there is a compromise in airway, when patient is desaturating, or there is any trauma or foreign body in airway. So despite of any reason, this can be classified into three broad heading like failure to oxygenate, failure to ventilate, or failure to maintain patent airway. So coming to few definitions that are commonly used in the ER during airway assessment are difficult airway, which is a clinical situation when a healthcare provider who is skilled at airway management experience difficulty with one or more recognized technique of maintaining airway. It is also defined as per institutional or local protocol. And in this context, healthcare provider in our setup is a emergency physician or anesthesiologist. Similarly, talking about the failed intubation is defined as a failure to achieve successful tracheal intubation in maximum of 3 attempts, irrespective of any technique used. Similarly, failed airway is condition when there is a failure to perform gaseous exercise in patient that cannot do on their own effort. Similarly, a very important topic or term that is commonly encountered in ER is a crash airway. That is a patient in a cardiopulmonary arrest or a deep coma who cannot maintain ventilation or oxygenation. And in today's presentation, we'll be focusing on the crash airway. So, crash airways should be managed quickly as per flow chart given below. That is initiated by back and mass ventilation and rapidly moving into laryngoscopy or surgical intervention. Based on the unique features of airway management, here we put a clinical consensus based on the four emergency medicine principle, that is priority to ventilate and oxygenate, evaluation before intubation, higher preparation, and simplest form of intubation. Here is a flowchart depicting management of a crash airway. Initially, we evaluate the patient, and if we suspect that whether the patient is in the cardiopulmonary arrest or patient is not able to maintain or oxygenate by their own effort, then we do a bag and mask ventilation. Despite of doing bag and mask ventilation, if the patient is not able to maintain the oxygen saturation or keep their airway pattern, we call for help, and we arrange the airway management cart, and we go for intubation by visualization or blind procedure. If that fails, we go for a supraglottic airway or visualization, and even that fails, we go for surgical management like cricothyrotomy or percutaneous tracheostomy. This compromises of a crash pathway, and if the patient is stable and is maintaining with oxygen therapy, we go with artificial airway. We go with a difficult division, and we go with a layman evaluation and laryngoscopy and tracheal intubation. Talking about a stable patient or unstable patient, these are both related terms. If the patient is very sick, we go with the crash pathway, and if patient is relatively stable, we go with the stepwise intervention. So, crash airway are the most common presentation in the ear. So, here are some of the tools to evaluate the patient in the emergency presenting with the crash pathway. So, we have whatever the layman. Layman is a look, evaluate, Mollem grading, obstruction, and neck mobility. It has a recommendation of 2C, and it has a specificity of 96.15 with a confidence interval of 89% to 99%, whereas sensitivity of 60% with confidence interval of 38 to 78%. So statistically speaking, lemon with a score of more than 3 predicts a difficult airway. So talking about the components of lemon, looking externally, facial trauma, large incisor, braid or mustache or large tongue is with 1 point. Similarly, talking about evaluation of 3 3 and 2 rule, incisor distance is 3 finger breadth, iometal distance 3 finger breadth, and thyroid to mouth distance with the 2 finger breadth is compromising of 1 point. Monoparty grading more than 3 compromises 1 point, and obstruction of airway compromises 1 point, and neck mobility compromise of 1 point, and total is of 10 point. Higher the points, higher, more difficult it is to intubate the patient. So, talking about Atlanto occipital joint extension, it is a angle between pharyngeal and laryngeal axis in arbitrary straight line. So more than 35, or basically talking about Atlanto occipital angle, grade 1, 2, and grade 1 and 2 suggest of normal laryngoscopy, whereas grade 3 and 4 have a different laryngoscopy, difficult laryngoscopy view. So as we talked earlier about 3 is to 2 is to 3 is to 3 3 3 2 rules. Here, part 3 is assessing mouth opening. A normal patient can open his or her mouth sufficiently to accommodate three of his or own finger between the upper and lower incisor. Similarly, second three is to evaluate the length of mandibular space by ensuring the patient's ability to accommodate three of his own finger between the tip of mentum and the chin neck junction bone. And similarly, two refers to the assessing the position of glottis in relation to the base of the tongue. The space between chin, neck, junction, and the thigh knots should accommodate at least 2 fingers of the patients. So the 3 3 2 rule first assess the adequacy of oral cavity, and second three addresses the dimension of the mandibular space to accommodate the tongue on the laryngoscopy. Here is a pictorial representation of 3 3 2 rules. So coming to the Mallampati grading, the Mallampati classification correlates the patient's tongue size to the pharyngeal size. This test is performed when the patient is sitting, head is in a neutral position, and mouth wide open and tongue protruding out. Patients should not actively phonate, which can result to the spasm of the muscles of the oral cavity. Here is the classification of the Mollem grading. There are 4 grades. Class 1 includes the visualization of soft palate, fauces, uvula, anterior and posterior pillar. Similarly, in grade 2, there is a visualization of soft palate, fauces, and uvula. Grade 3, there is a visualization of soft palate, base of uvula, and grade 4, there is a visualization of only hard palate. Here is another grading of another type of grading of visualization of epiglottis in Cormac-Lance scores. Grade 1 reflects fully exposed glottis view, and grade 4 reflects the inability to visualize any of the vocal cords. The percentage of glottic opening provides alternative glottic visualization rating from 0 to 100%. Epiglottis can be visualized by doing port maneuver, that is backward, upward, and rightward pressure. Here is the grading of Cormac-Lance scores. In grade 1, there is a full visualization of glottis, whereas in grade 2, there is partial visualization of glottis, and in grade 3, there is only epiglottis is visible, and in grade 4, neither of glottis or epiglottis is seen. So, depending upon the visualization of glottis, epiglottis, there is likelihood of difficulty of intubation. Here is another test, bedside test that can be done in the ear. That is the upper lip bite test. Class 1, whose lower incisor can bite upper lip above the verminal line. Class 2, lower incisor can bite the upper incisor lip below the verminal line. And class 3 says that lower incisor cannot bite the upper lip. The upper lip bite test, prevalence of airway difficulties according to direct laryngoscopy viewed from 2.8 to 27% according to upper lip bite test. So it is one of the easy bedside tool that can be used to assess the difficulty in airway intervention. So another tool that can be used for predicting the difficult airway in the ER is bag and mask ventilation. So these are the predictors, that is mask seal, obesity, increased age, lack of teeth, and stiff lungs with any patient with lungs pathology. These are the factors that may indicate patient will have difficult bag and mask ventilation. Here is a grading for difficult mask and ventilation. Grade 0 says that patient might not require bag and mask ventilation, or patient is not being bag and mask ventilated. Grade 1 says that one person can do bag and mask ventilation. Grade 2, patient is able to ventilate by mask with oral airway or other adjuvant. That similar, grade 3, patient has a difficult mask and ventilation, or patient might require uh, two healthcare provider to be bag and mask ventilated. And whereas grade 4 says that patient is not able to be bag and mask ventilated despite of two or more healthcare provider. Similarly, in crash airway, a patient might have to undergo surgical intervention. So these are the indicators of difficult cricothyrotomy. The mnemonics with sorts. Patient has a history of surgery or any other airway obstruction. Patient has history of or condition of hematoma in the airway, externally or internally. Obese patient, radiation, and tumor. So these are the bedside tools that can be used to assess the difficult airway. So coming to pediatric airway, we need to understand what is difference between the infant and adult airway. So talking about that, infant has large prominent occiput, whereas the adult has a flat occiput. Tongue in the infants are relatively large, whereas in adult it's relatively small. Larynx is cephalad, and whereas in adult larynx is a bit caudal, that is C4 and C6. Epiglottis in infants are omega shaped and soft, which is prone to injury. Similarly, in adults it is flat and flexible. Vocal cords in infants are short and concave, whereas in adults it's horizontal. In infants, the narrowest portion in the is cricoid ring below the cords, whereas in adults it is vocal cord. In the infants, cartilage are soft, whereas in adults it's firm. And in infants, lower airways are smaller and less developed, whereas in adults it's more rigid and large and developed. So it's quite different in infant to intubate or to maintain airway. And infants' airway are more easily collapsible or difficult to maintain. So assessing the pediatric airway in emergency, we use COPUR index. So with a C, it's a evaluation of genes from side view. Each is scoring 1, 2, 3 points. One says normal. Two is small, moderately hypoplastic. Three markedly recessive. Four extremely hypoplastic gene. So O stands with opening of mouth. That is score once goes with mouth opening more than 40 mm. If there is a mouth opening of 20 to 40 mm, score 2. If mouth opening is 10 to 20 mm, score 3. And if the mouth opening is less than 10 mm, it's uh, score 4. So there is a scoring for previous intubation or obstructive sleep apnea, and if there was a previous easy attempt, then score is 1, and if there was previous difficult intubation, then the score is 4. So talking about the uvula, there is a if tip of uvula is visible, its score is 1, and if only soft palate or only hard palate is visible, the score is 4. And with the range of motion of the neck, if the range of motion is more than 120 degree, there is score is 1. 60 to 120, score is 2, and 30 to 60, score is 3, and if less than 30, score is 4. So with the score cumulative score 5 to 7, the child might have a normal intubation, and if the score is more than 10, patient might have a difficult airway, and we might face problem in maintaining the airway. So if the patient scores more than 16, we might have to consider awake intubation, that is a potential tracheostomy or cricothyroidotomy. So, summarizing the procedure presentation, while maintaining any of the airway in adult or pediatric population, we must look for obstruction, cyanosis, and AVPU score. Similarly, we must be assessing the patient breathing sound, stridor, noisy breathing, and we must be clinically assessing whether is a obstruction or the facial injury. And meanwhile, doing this, we must be evaluating and reassessing the patient. So here are some of the examples of a difficult airway. This patient has a retrognatic mandibular or micromandible. So similarly, here is another patient with that has a enlarged tongue, probably. So this kind of patient presenting ER might have a difficult airway. So summarizing to their predisposition, if any patient presents with the crash airway, we must follow the crash airway algorithm mentioned earlier. If patient is relatively stable, we might go with a difficult airway algorithm, and uh, else we can go with a rapid sequence intubation. So today's presentation summary is we have to identify what type of the airway the patient has presented. We must be able to assess Layman scoring, Bonham-Patti scoring, Cormack-Lens scoring. Uh, if needed, we must use muscle relaxant, and all of this must be used by all the uh, healthcare provider in the emergency. So this is a caveat said by American Society of Anesthesiology. Failure to evaluate the airway and predict difficulty is the single most important factor leading to the failed airway. Thank you. And this ends my presentation, and the floor is open for the question. Thank you.
Thank you, Dr. Sunil. It was a nice presentation on a very important topic that we face in our day-to-day duty in every shift with every patient. So as Sunil has said, the floor is open for discussion. Any questions, please? Dr. Sunil, one question is if someone like to ask question in, they can put their questions in chat box as well in the meantime. My question is, Doctor, to what is there any quick tool so far you have presented that we can assist in an unconscious patient who can't open his mouth or we can't awake him or who is not conscious?
Thank you, Dr. Sani, for the question. There is no any gold standard tool to assess the airway. It's not said that any of the tool is superior than another tool. Basically, it depends on the clinical judgment and practice of the clinician to judge the airway. And most commonly used tool is Layman tool, and there is another tool that has modified version of Layman, which does not include Molam putty grading. So it just includes look externally, evaluate obstruction and neck mobility. So this might be used to evaluate any patient without opening their mouth. So it has been superior than the Layman, so it can be used in the emergency setup. Thank you. I hope this will answer your query.
Thank you, Dr. Sunil. It does. It definitely did.
Mm.
So, can you please explain more about that upper lip bite test, Dr. Sunil?
Sorry, I didn't get your question.
Can you explain more about that upper lip bite test?
Thank you, Sunny. Upper lip bite test uh, is a test that will assess your airway in the emergency setting, and for this, the patient has to be compliant enough so that they can bite their lip. So, in this test, patient is asked to bite their upper lip with the lower teeth, and our landmark is the Barmilian line. And if any patient is able to bite uh, their upper lip above Barmilian line, it's class 1, that will say that there will be an easy intubation or laryngoscopic view. And if patient is not able to bite their lip at all, then patient might have a difficult laryngoscopy view. So according to a study of a prevalence of difficult airway, direct laryngoscopy view varied from 2.8% to 25%, and in a upper lip bite test, it was 2 to 21%. So in 11%, 11 out of 27 studies, upper lip bite test was sensitive. So it is considered a handful tool in the bedside setting. Thank you.
Dr. Sunil, I'd like to ask one question.
Yes, Dr. Ayas.
The cricket pressure has been replaced with the bark maneuver these days.
Okay.
Why bark maneuver is superior than cricket pressure? Could you put it the logic behind it? Thank you.
Uh, in cricket pressure, we apply pressure directly posterior on the cricket. That has not been shown to be effective in preventing gastric reflux. Whereas in burp, we apply backward, upward, and right and posterior pressure. That is more anatomically driven and most likely to prevent gastric reflux.
Thank you.
Mm.
Are there any more questions, or anyone would like to focus on some discussion? You can put your queries and discussion part in chat box as well. And we are moving to the summary part. I would like to request Dr. Ashish sir to um, uh, have his saying or summary. Thank you, sir. I suppose Dr. Ashish sir do not, sorry, is busy, I guess. So, Dr. Sunil, could you please
Mm.
summarize today's presentation in few words, and we can move to the in part.
Thank you, Dr. Sunny. आजको हाम्रो प्रेजेन्टेसनको मुख्य उद्देश्य भनेको चाहिँ हामीले इमर्जेन्सीमा चाहिँ क्रास एयरवेलाई चाहिँ रेकग्नाइज गर्न सक्नु हो। कुनै पनि पेसेन्ट इमर्जेन्सीमा कोमाको स्टेट या कार्डियोपल्मोनरी अरेस्टको स्टेटमा आयो भने चाहिँ कसरी चाहिँ हामीले उसको एयरवेलाई प्याटेन्ट राख्ने या एयरवे एसेस गरेर एयरवे कसरी कम्पिटेन्ट राख्ने भनेर चाहिँ थाहा पाउनुपर्छ, इन्डिकेसन के हो र त्यसलाई कसरी रेकग्नाइज गरेर कसरी मिटिगेट गर्ने त्यो चाहिँ हामीले थाहा हुनुपर्छ। हामीलाई इमर्जेन्सीमा थाहा हुनै पर्ने भनेको लेमन भन्ने टुल थाहा हुनै पर्यो र त्योभन्दा राम्रो अहिले नयाँ मोडिफाइड लेमन या LEON टुल भनेर छ, त्यो चाहिँ थाहा हुनु पर्यो। त्यो बाहेक चाहिँ कुनै पनि टुल सुपेरियर या इन्फिरियर या कुन चाहिँ बेटर भनेर छैन। आफूलाई जुन चाहिँ सजिलो लाग्छ या जुन चाहिँ कन्फिडेन्स लाग्छ त्यो चाहिँ प्रयोग गर्न सक्नु पर्यो। र इमर्जेन्सीमा चाहिँ हामीले कुनै पनि एयरवे हामीले एक्लै म्यानेज गर्न सक्छौँ भन्ने जरुरी छैन। त्यसैले चाहिँ हामीसँग हाम्रो सिनियर या हाम्रो कलिगको चाहिँ बेला बखतमा आवश्यकता परे अनुसार चाहिँ सहयोग लिनुपर्छ। सो हाम्रो अमेरिकन सोसाइटी अफ एनेस्थेसियोलजिस्टले पनि भनेअनुसार failure to evaluate the airway and predict difficulty is the single most important factor leading to the failed airway. So हामीले चाहिँ एयरवेलाई चाहिँ कतिखेर डिफिकल्ट हुनसक्छ भनेर त्यो चाहिँ अर्ली एन्टिसिपेट गर्यो भने चाहिँ हामीले एयरवे पनि प्याटर्न गर्न सक्छौँ र पेसेन्टको पनि लाइफ बचाउन सक्छौँ। यति भन्दै आजको प्रेजेन्टेसन यही समाप्त गर्न चाहन्छु। धन्यवाद।
Thank you, Dr. Sunil. It was a nice, sweet and short and sweet presentation. Very nice evening. So this is the end of today's presentation and today's session of Knowledge Cafe. Merry Christmas. Good night to everyone. Thank you.
Thank you all.